Good morning, everyone. Hope everybody's ready for our head and neck cancer webinar today. As everybody knows, this is the Head and Neck Cancer Awareness Month, so we are very excited from Delta Dental of Minnesota to present this webinar today. We have some great speakers, and in addition, we also have a patient who I hate to say this is a cancer survivor, but Tristan's story is wonderful to share. So we're excited about sharing the story from Kristen. But before we go, a few housekeeping items. We are really looking forward to hearing all your questions today. So if you don't get to your question today, we will definitely reach out, but feel free to ask questions in the chat box. In addition, continuing education certificate will be emailed to you some point next week. So look for that in the email that you shared with us to register for the seminar, for the webinar. And then survey, there will be a really short 3-question survey at the very end. So please take a minute to provide us your feedback. We'd really look forward to hearing from you. That being said, I'm handing it over to Tristan. Tristan, take it away.
Thank you so much. I just want to say, first off, I appreciate the opportunity to tell my story of my ordeal that it's been the last couple of years. So I'm happy to be here and I appreciate the opportunity. So my adventure, if you will, began back in the summer of 2018. I travel for work and I was working out in North and South Dakota for a couple of weeks when I started to develop what I had thought was a canker sore on the side of my tongue. I had a kind of a chipped molar in the back that was rubbing against it. And so I didn't really think anything more of it from that point. After about 4 weeks, it got a little bit bigger and it got to the point where it was really kind of hurting and aching. So as soon as I got back to Minnesota where I live, I went to the dentist to see if she could figure out what was going on with it. As soon as I got to the dentist, she took one look and she was like, well, this doesn't look like it's a canker sore. It looks like it's something a little bit more serious. So I think that you should see somebody about it potentially being cancer. I was super fortunate. I was able to end up same day getting to see Dr. Kademani and Julie Klein, and they did a biopsy right there on the spot. 2 days later, the biopsy results came back and it turned out that it was cancer in my tongue, and happened much faster than I ever anticipated, which I'm grateful for now. At the time, I was a little anxious, but in less than a week, we went through with surgery. They removed a portion of my tongue and a bunch of my lymph nodes in my throat to hopefully get everything taken care of. They sent the lymph nodes off to the tumor board, and it turned out that it wasn't advanced enough that I needed radiation or chemo, which was great. So we all kind of thought that that was it and we were good to go. I had been a pretty heavy smoker for over 10 years and nothing will get you to quit smoking like that news. So everything was fine for a while. I got married in the summertime of 2019. Towards the end of 2019, we found about an almond-sized lump in my throat. We biopsied it a couple of months later, and it turned out that it was more cancer. So we had to remove that. And then as Dr. K said, I earned myself some chemo and radiation. So towards the end of February of 2020, before the pandemic and the shutdown hit, I started my 6-week adventure with chemo and radiation. So that was pretty rough. It was exactly how they kind of describe it, like nothing is crazy like head and neck chemo and radiation. The first couple of weeks were kind of a breeze. I had my sense of humor, which I've always prided myself on. By the 4th week, I remember coming into radiation and the techs were like, oh, how are you feeling? You still got that sense of humor? And I was like, nope, not anymore. It was absolutely rough, but now looking back, I think it was, made me stronger, gave me a better outlook on life, and I'm grateful that I got out through the other side. Lost 80 pounds. There are easier ways to do that, I'm told. But as of now, it's been since the spring of 2020 that all my scans have come back clean. So everything is going in the right direction, which is really good. But so yeah, that's kind of the long and the short of it. I'm now hoping that I'm pretty much on the other side of it. I have a fantastic team with Dr. Kademani and with Julie Klein, Dr. Bauman at North. I couldn't be luckier, and I'm just hopeful for the future. But that's about it.
Thank you, Tristan. Thank you so much for sharing your story. And we're so thrilled that you are on a great path. Thanks to our next speaker. So our next speaker is Dr. Kademani. And it's hard to get Dr. Kademani's bio concise. So I'm trying to do a good job of keeping it concise, but he is currently the Chief of Staff at North Memorial Medical Center and Fellowship Director of the Head and Neck Oncologic and Reconstructive Surgery and Fellowship Program with the Minnesota Head and Neck Surgery in Minneapolis. He has both a dental and a medical degree and a surgical residency in oral and maxillosurgery surgery education from the University of Pennsylvania. And I'm lucky to say he's from my alma mater, so I'm pleased. In addition to his illustrious clinical career, he has authored and co-authored over 100 books. He has edited 2 textbooks, and primarily one of them being on improving outcomes in oral cancer. He's also a very illustrious speaker, has done multiple speaking engagements, over 300 nationally and internationally, and primarily all of them being on oral cancer, reconstructive head and neck surgery. So we are extremely lucky to have him as one of our speakers today. Dr. Kademani, take it away.
Well, thank you very much, Dr. Prabhu. It's my great privilege to be here with actually Delta Dental and all of you to talk about something that's very near and dear to me, which is the management of head and neck cancer, but also to bring awareness to this disease as well. As you all know, that April is Head and Neck Cancer Awareness Month, and these are very special programs that we've put on for probably about the last decade to really improve the awareness of head and neck cancer for our local medical and dental community. I don't have any financial disclosures, and I want to thank not only our patient speaker, Tristan, for doing such a great job in outlining his actual story. And this is the reason why we're all here. We're all here because we take care of patients, but we also see the struggles that they all go through. And it's so important for us to, as a collective profession, to try to improve these outcomes, diagnose patients with earlier stage cancers, so we can really mitigate the complexity and the morbidity of treatment that they go through. I want to thank my friends and colleagues at Delta Dental for really being pioneers in this field, for co-hosting the program, and for all the work that they've done in improving the overall health of our population. So as you're all aware, April is Head and Neck Cancer Awareness Month, and this is really a very special time for us to be able to recognize what the disease is, be able to diagnose it with earlier stage disease, also celebrate the lives of patients that we're able to save, and to remember those that we've lost as well, and to be able, as a collective, to be able to actually advocate for things that are often unaware for our patients that have head and neck cancer. There's lots of insurance issues that our patients go through. There's lots of social and psychological issues that patients go through when they're diagnosed with head and neck cancer, and it's important for us to be able to actually recognize these things and provide them that support. And that's the reason why I began in late 2020 a Head and Neck Cancer Foundation to really be able to help our patients with many of these types of issues. So I'm going to begin my presentation with a little bit of a preamble about how COVID has severely impacted not only the practice of medicine, dentistry, but also surgery. So as we all know, the first case of COVID was diagnosed in December of 2019 in Wuhan, China. It's got a relative R index of 2.8, which effectively means that one person with COVID affects or infects 2.8 other people. The first healthcare worker to succumb to the disease was in January the 25th of 2020. That was an ENT surgeon. And throughout this time now, we've seen that our relative rate of impact of COVID in healthcare practitioners is around about 3.8%. That has a great degree of variability across the world, with some parts of the world, particularly in Europe, in the initial phases of the infection, being almost a third of the infections were occurring in healthcare actual workers. We've seen an average death rate of healthcare practitioners being around about 0.4%, and that's actually worldwide. Now we know that the relative transmission of COVID from patients to healthcare workers is relatively rare as long as PPE is worn in the correct manner. Most of the healthcare transmissions tend to occur from to healthcare workers in social settings. There are several high-risk populations for the transmission of COVID-19. Because the virus is harbored in the oropharynx, there's certain professions such as anesthesia, pulmonary and critical care, otorhinolaryngology, thoracic surgery, oral maxillofacial surgery, and of course dentistry that are the highest risk of transmission. So what does this really mean? I mean, we're at such high risk in terms of the transmission of the actual virus. We are working in the oropharynx. We are doing aerosolizing procedures. We have close proximity to high areas of viral burden. And during what was effectively a shutdown of elective medical and dental care, we saw many of these patients have delays of care that really went to the emergency room for emergency dental care. And as we all know, this is not the right environment. We also struggled with shortages of PPE. We had conflicting federal and local guidance on how to manage patients. And as we have come out of this now, or beginning to see the light at the end of the tunnel with now a vaccination rollout, what we've really seen is a great deal of stress and resiliency issues in healthcare practitioners. We've seen a lot of early retirements. We've seen a lot of practices going for sale. So these types of issues are not insignificant to our profession, and we need to be actually mindful of all of those things and to help each other as we continue to work through all these times. This has not only affected us, but of course this affected our patients. They've become fearful of healthcare environments. As you know, they've had delays of elective medical and dental treatment. Many of them are in financial insecurity, and as I've already mentioned, are seeking emergency care, emergency dental care in our local emergency rooms. We're entering a new phase now of vaccine hesitancy, and although about 50% of the state of Minnesota now is vaccinated, we still have a long way to go. And Dr. Crespo will be talking about some of these actual issues in her presentation. With regards to cancer care, I think that one of the things that we struggled with is that the American College of Surgeons, during the shutdown, which was between March and May of 2020, really categorized elective cancer treatment as elective. We all know that's not the case, but we saw significant delays in our abilities to care for patients that were initially diagnosed with head and neck cancer during that period of time. And we've still continued to see elective rates of surgery decrease by around about 15%. So as an oral and maxillofacial surgeon that has practiced in the state of Minnesota now for around about 17 to 18 years, although I'm a oral maxillofacial surgeon and do all the general procedures such as extraction of wisdom teeth and placement of dental implants, a lot of my work and professional activity has been dedicated to the care of patients with head and neck pathology, and in particular head and neck cancer. On any given day or week, we may see a number of patients that have a variety of head and neck pathologies, from relatively innocuous lesions to ones that look obviously malignant and need care. But this is the wide range of presentation of clinical disease that we may see as dental practitioners. What we've really seen is this acceleration of virtual care and telemedicine. And as we've evolved through this process with the pandemic, we've really instituted a telemedicine program, which has accelerated how we take care of patients. But what we've done is, because we see patients from all over the state, we've really put together a pilot telemedicine program for oral lesions. So if you call or text this phone number, 612-581-1319, this is a phone that's carried by our nurse practitioner, with a brief clinical history and a picture of the lesion, we will provide you some clinical guidance back within 24 hours with treatment recommendations. And we found this program to be actually very helpful. It helps our practitioners when they don't have easy access to actual local expertise, but it's been very beneficial for patients too, to ensure that their lesions have a degree of surveillance and are actually looked at, and there can be some clinical documentation in both our chart and in the local dentist chart about a management strategy for that lesion. So here's what it might look like. We get a picture of a lesion like this, which is a diffuse leukoplakia on the lateral border of the tongue, with a brief clinical history, which is a 36-year-old male with a new onset white lesion, presents for more than 14 days without any history of trauma. And based on the clinical presentation and the history, our recommendation back to that practitioner is an incisional biopsy. Further guidance can be provided, and this can be done either by the actual local dentist, by the local oral maxillofacial surgeon, or be referred for tertiary level care. So I'm going to switch gears a little bit now and just talk in general about oropharyngeal cancers. So as many of you know, it's the 6th most common cancer worldwide, and then actually occupies about 3% of all human malignancies. Here in North America, we see about 50,000 new cases per year, with about 9,700 deaths annually. And unfortunately, if you look at that from a time frame, that correlates to approximately 1 person every hour dying from oral and pharyngeal cancer. And this is a global phenomenon too. We see patients, we see the incidence of the disease all over the world is actually increasing, and there's certain hotspots, certainly in Southeast Asia, Australia, North and South America, actually occupy by far and away the vast majority of disease. The majority of these lesions are squamous cell carcinoma, well over 90%. And unfortunately, we still have 50% of patients that are diagnosed with advanced stage disease, which is why programs like this are so important. We all know that the prognosis of patients really depends upon the stage. And if we're able to de-escalate stage and diagnose patients with stage 1 and stage 2 disease, our survival is significantly better. Patients do much better. They can avoid radiation and chemotherapy, and their overall survival benefits significantly better, that I'll talk about in just a second in more detail. In 2017, the World Health Organization reclassified oral pre-malignant lesions, and it really prompted me to put together a textbook which was on improving outcomes in oral cancer. Part of what the World Health Organization did was to reclassify all pre-malignant lesions. And so not only were they leukoplakias or erythroplakias, but all lesions that had pre-malignant potential were then reclassified with treatment algorithms that I will talk about in just a second. By far and away, most of the lesions that we have to deal with are either a leukoplakia or erythroplakia. And I'll talk about them individually because they're both slightly different. So a leukoplakia, by definition, is a white patch that you cannot remove from the mouth and needs a histologic diagnosis for confirmation. Now, approximately 4 to 15% of leukoplakias are dysplastic. The mean malignant transformation rate of leukoplakias in general is around about 1 to 2%. And some studies have it reported as high as 12%, in particular those patients that have dysplasia as part of their leukoplakia diagnosis. And that's an important distinction that you need to understand. And this is the wide variety of leukoplakias that we may see, very diffuse, as in the lesion that I showed you with our telemedicine program, but they may be thick, they may be corrugated, granular, or verrucous in clinical appearance. And all of these lesions have the risk of containing pre-neoplastic or dysplastic changes. But not all white lesions are leukoplakias, and this is where our clinical diagnosis comes into play in being able to differentiate which lesions we need to be concerned about. And in general, if you're unsure, a tissue diagnosis is by far and away the safest approach. But certainly contact dermatitis, nicotinic stomatitis, lichen planus, frictional hyperkeratosis, and chemical injuries can all look very comparable to the traditional types of leukoplakias. So, as I've already mentioned, the transformation rates of leukoplakia really correlate to the degree of dysplasia that is present. The higher the grade of dysplasia, the higher the rate of malignant transformation. And it's important to understand that usually once a diagnosis of leukoplakia or dysplasia is made in the oral cavity, there's usually a transformation period of 2 to 4 years where that lesion will undergo malignant transformation if it's going to transform in the first place. There are certain risks of these lesions that we have to understand, and certainly the size, the site with the tongue and the floor of the mouth being the most prevalent. Most commonly in female patients and non-smokers tend to be the highest risk, and I'll talk about this in just a second. Erythroplakias, in a very similar vein, are red patches, and again need a biopsy for a histologic confirmation. The main difference about erythroplakia or speckled erythroplakia is about 90% of these lesions tend to be dysplastic or harbor carcinoma in situ or frank malignancy. And I just operated on a patient on Monday that had a very diffuse leukoplakia that, sure enough, after a wide local excision, did contain areas of microinvasive cancer. So this is a real phenomenon that these red and white lesions need to be interrogated and carefully monitored. And here's an example of a erythroplakia on the lateral border of the tongue that harbored an area of squamous cell carcinoma. And just like in leukoplakia, not all red lesions are pre-malignant. So again, the clinical diagnosis and the history of the patient is going to be key. We certainly have vascular lesions, traumatic lesions, and a variety of other clinical scenarios that can present as a erythroleukoplakia that we need to be mindful of. And these are real diagnostic challenges. So on the left, we have a patient that has a hyperkeratosis histologically proven. I would argue that the lesion on the right-hand side, which is a squamous cell carcinoma, looks almost identical to the lesion on the left. So again, clinical diagnosis, even in the most experienced hands, is not 100% accurate, and therefore the ability to have a histologic diagnosis and appropriate tissue diagnosis is going to be the most important. As I've already mentioned, when the World Health Organization reclassified oral pre-malignant disease and their risk of transformation in 2017, there were several features of a lesion that we have to pay attention to. First of all, it is the size of the lesion. So greater than 20 centimeters square is going to be a critical feature. The texture of a lesion, so non-homogeneous and thicker lesions tend to be more concerning. The more red a lesion is, the higher rate of malignant transformation. And the site in the tongue and the floor of the mouth are other features. Also, when a histologic diagnosis is performed, the presence of severe high-grade dysplasia also is a predictive marker of early malignant change in these patients. So in general, the indications for biopsy are any red, white, or mixed lesion that's present for more than 2 weeks or 14 days that cannot be clinically diagnosed and is not attributable to any other source should have a biopsy. And we have to understand that what we are seeing when we look at a lesion like this on the oral surface of the tongue is that we're not only seeing a clinical lesion, but we are seeing a number of histologic changes that occur at the microscopic level, with cells becoming more and more dysplastic, actually going from normal mucosa all the way to carcinoma in situ and invasive cancer, which by definition is violation of the basement membrane and the ability for that lesion to then metastasize. But we're also seeing chromosomal changes that are beginning to occur, and a whole host of gene and protein aberrations that are beginning to occur in this process. Now, these chromosomal and protein types of changes occur well in advance of the morphologic changes that we see in the oral cavity. And we've actually looked at this and through a variety of markers. And in general, there needs to be around about 10 to 12 genetic aberrations that tend to occur before we begin to see the clinical appearance of a dysplastic lesion. So although we may see very small areas of leukoplakia or erythroplakia on our clinical examination, what you really have to understand is that this is a long-term genetic process that is beginning to occur, and these events need to be taken into consideration in how we are counseling our patients and the treatment that we're going to prescribe for them. In 2011, Hanahan really described the hallmarks of carcinogenesis and really took what I have just been talking about and really put it into a very nice algorithm and looking at all those pathways that tend to get affected for our patients to go from cellular changes at the gene and protein level to being able to see the presence of clinically obvious lesions that can occur after many years. These pathways have also been used and targeted for new methods of chemo and immunotherapy. And not all the lesions that we see are very discrete. And then obviously when you're presented with lesions like this, there's no question that these lesions are pathologic and most likely malignant. But as I've already demonstrated, not all patients tend to present like this. So our trained eyes and careful assessment, being thorough with our head and neck examinations is going to be key if we're going to de-escalate stage, find earlier stage lesions, and be able to save patients' lives. I want to spend a few minutes and talk to you about the management of dysplasia. So we've already spoken about some of the features of erythroleukoplakias and leukoplakias that we get concerned about. And so in 2017 and 18, I was asked to write some editorials in PPOELS to really correlate with the changes in the World Health Organization reclassification system. So what I did is I really took best practices in terms of clinical care and looked at how we want to manage patients with mild, moderate, and severe oral epithelial dysplasia and put pathways in place that not only can we place a diagnosis onto these patients, but have them counseled in a way that we can continue to monitor them in a long-term way. So in general, when you have a red or a white lesion that you're concerned about, the first step is to really get a histologic diagnosis. Once you get that histologic diagnosis, you're able to then risk stratify that patient into either a low risk based on what that pathology shows you, if it's mildly dysplastic, has no dysplasia, or if it's hyperkeratotic, or a patient that is at high risk of malignant transformation that might have moderate to severe epithelial dysplasia or carcinoma in situ. The last, when we have the more severe histopathologies, we tend to want to actually excise those lesions and put those patients into a much closer monitoring program. The other part of the monitoring program is also to remove their associated risk factors. So if patients consume a lot of alcohol, if they smoke, these are all things that need to be spoken to the patient about and also documented. We know that the failure to diagnose and failure to treat oral lesions and conversions into malignancy is also one of the highest rates of malpractice for the dental profession as well. So having a rigorous follow-up plan is also going to be key for to avoid any types of malpractice issues that you may encounter in your practices with these types of patients. I've already mentioned that early detection is going to be key. So what we want to do is to not only take this patient that has a very diffuse yet minor oral leukoplakia, be able to diagnose them with earlier stage disease, diagnose them at a molecular level, and treat them in a pre-neoplastic setting before they convert. And so these are going, so our abilities to do this, is no question, is going to save a great deal of morbidity and mortality for our patients. It's going to decrease the cost of overall healthcare, and it's going to improve our patients' lives. But we all know that these lesions can be very biologically unpredictable. We can have lesions like on the left that stay that way for a long period of time, or when they come back for follow-up, have converted and look a lot more diffuse. And so a rigorous follow-up plan and being able to understand the biologic progression of lesion is also a factor that we get very concerned about. We know in the general head and neck cancer population that we have approximately 206 days of delay in terms of when that patient first has the appreciation of symptoms by the time they work through the process of seeing their dentist, having a referral, having a tissue diagnosis, by the time they get to a tertiary level practitioner like me, is around about 206 days. It would be great to be able to shorten this time frame, but what we've also seen during COVID is that we've seen approximately another 9 to 12 months of additional delay onto this because of fear of treatment, delays of elective care. So we really need to pay attention to this as we're coming out of the pandemic in terms of being very diligent in how we're screening patients. And this is a classic example of a story that I hear every day. So this is Jill. She's a patient I've been taking care of now for probably well over 15 years. When I first met her, she was in her early 30s and walked into my office with her 3 children, all under the age of 10, and told me a story that is so typical. And I think it's important that is shared, particularly during head and neck cancer awareness. Jill has spoken on many other programs actually with me, and I just want to take a moment to thank all of our patients for really sharing their stories. They're the ones that we're here for, and it's been a privilege to take care of them for all of this time. So Jill came in with a story that's very, very typical. So she says that she saw her dentist for a sore on her tongue. She also saw her family care practitioner and also a local ENT surgeon, and saw some other dental specialists as well over a 2-year process. Really, nobody could figure out what was going on with her. She had some ear pain, she had a little bit of difficulty swallowing, but all of her clinical exams and radiographic assessment by multiple practitioners all turned out to be negative. She eventually developed a bump in her neck. It's when she got very concerned. And at that point, a biopsy was done on what was a very diffuse area on the lateral border of the tongue. This area eventually confirmed the diagnosis of invasive squamous cell carcinoma. So when she came to see me, she had a firm nodule on the lateral aspect of the tongue, and she had a neck mass. She was staged as a T2N1 stage 3 squamous cell carcinoma of the lateral border of the tongue. And this is what she went through. She went through a partial glossectomy. She went through a neck dissection, as you can see the specimen on the top right-hand side. She went under microvascular reconstruction with a radial forearm free flap. On the picture on the left, you can see Jill's half her tongue is native and half the tongue is a free flap. Here's a donor site on her arm. She looks great, she feels great, she's been free of disease. However, because she had advanced stage cancer, she underwent radiation and chemotherapy. Now, she does not have a PEG gastrostomy tube in place. She's able to eat, and she doesn't have a tracheostomy tube in place. She did have those for a period of time as she convalesced, but she'll tell you that her quality of life, she's grateful to be alive. Her son is in medical school now. But you know, the other things that she's been through are really challenging. She can't taste food completely. She's not fun to go out to a restaurant with because she has to eat so slow. So all of these things have really affected her overall quality of life. I sit on the American Head and Neck Society, and really on the Prevention and Early Detection Committee, and our guidelines are really that any lesion that is concerning as a premalignant lesion needs to have a tissue diagnosis as a gold standard. And this is really the same that has been supported by the American Dental Association and their Clinical and Scientific Advances Committee that I'm also privileged to actually sit on as well. It's important to understand that we in the dental profession really have a unique ability to actually shape the diagnosis of our patients. So whenever I get a diagnosis from a dental practitioner, either a general dental practitioner or a specialist, I know that in general, those patients are going to be diagnosed with earlier stage disease, stage 1 and stage 2. When I see patients from primary care physicians or from other medical specialists, like ENTs or dermatology, those patients tend to be diagnosed with more advanced stage disease, stage 3 and stage 4. And the primary reason is because patients tend to go to those providers when they develop a neck mass. Unlike when they have an oral lesion, they usually see their dentist. I'm not going to talk too much about HPV. I'm going to let that sit with Dr. Crespo, but just to let you know that HPV now is an independent risk factor for oropharyngeal cancer. And we've really seen since 2003 a significant rise in the incidence of head and neck cancer. Most of this is associated with human papillomavirus. And if you look year by year, we've seen approximately a 6% rise in rate of oropharyngeal cancer that's now become in epidemic proportions. Just to bring home the point about why stage is so important, when we diagnose patients with stage 1 disease, we're able to save their lives. and the morbidity of treatment is significantly better. A patient with a stage 1 oral cancer has about an 85 to 90% 5-year survival. And when we're talking about somebody like Tristan, who's very young and who's having to struggle with disease, that's a very difficult conversation to actually have. Looking at stage 4, the 5-year survival of a patient with stage 4 disease is only 25%, or 1/4 of a stage 1 patient. And that is with the addition of surgery, radiation, and chemotherapy. So you see the importance of trying to diagnose patients with earlier stage disease. And just as we get wrapped up, I just want to really extend it for our patients. I've had the privilege of taking care of so many patients over my career. I have a practice that has thousands of head and neck cancer patients, and they all are very special people. I'm just humbled by their strength and their courage that they go through the treatment that we actually propose. So not only Tristan, but Jill and now Brooke. I'm really grateful for the privilege of being an actual doctor and for being able to take care of them. This is not work that I do on my own. I have a team of actually excellent practitioners around me that help me to take care of these actual patients. And again, our parting note is really the importance of de-escalation of stage and finding patients with earlier stage disease. I want to thank our moderators and our patient speakers as well. Here's my contact information if you have any questions, and I'll be glad to take any questions. Thank you very much.
A lot of great information for us to learn and digest, and we appreciate all your expertise on this topic. So I'm sure we're going to get a ton of questions. So if you haven't and you have a question, please feel free to type it in the Q&A and we'll answer it as we go along. I think one of the questions that came up was, will we, if we leave and come back, you know, we missed a few things. Is there going to be a recording? Yes, there is going to be a recording of the webinar. It's definitely not going to be for CE credits, but it's definitely going to be available for information for the anybody who's joined the webinar session today. I didn't get a chance very much in the beginning to tell you who I am, and part of the reason is I'm going to share. My name is Dr. Nina Prabhu. I'm the Vice President of Dental Services at Delta Dental of Minnesota. And I have the awesome pleasure today of introducing my friend and my colleague as our next speaker, Dr. Eileen Crespo. She's fun to work with, and she is just the champion of prevention of head and neck cancer. So I've had numerous conversations with her on this topic. Dr. Crespo's background, she's a practicing pediatrician with more than 20 years of experience. She completed her medical degree at the State University of New York, Buffalo School of Medicine and Biomedical Sciences. She then completed a pediatrics residency at the University of Minnesota, and she was a chief resident in pediatrics. So it gives me great pleasure to introduce my friend and colleague, Dr. Eileen Crespo. Dr. Crespo, take it away.
I want to thank the previous presenters. It's a hard act to follow, but I'll do my best. Today, we're going to be talking about how to create vaccine champions by working together. I think that's a lot of the sentiment today with these webinars is really the importance of the medical and dental community coming together with the goal of excellent patient care and better outcomes for our families and patients. So, okay, I'm going to use this as the, okay. So we're going to cover the decline in immunization rates seen with the pandemic. We'll also recognize the role of healthcare providers in combating misinformation and vaccine hesitancy. And we're going to discuss the role of dentists in vaccine advocacy today. So this slide is familiar to many of you. This was the state of affairs just over 1 year ago as the World Health Organization The Center for Disease Control and Prevention here in the United States recognized that COVID-19 was coming and was a significant public health threat. Schools everywhere shut down and kids stayed at home. And shortly thereafter, everything seemed to close down. So all non-essential businesses had to close. The Mall of America had to close. And I find it somewhat humorous, knowing what we know now, that initially they were going to close for 2 weeks. And no one could anticipate what would come in the aftermath. There were some good things that came from these closures. We know that when kids stay at home and people aren't congregating, socializing, or going to work, influenza-like illnesses dropped off significantly. On this slide, the dark green colored graph there shows you the 2019-2020 influenza season. And that's the percentage of visits for influenza-like illnesses. And you can see the very precipitous drop-off of influenza activity in the community that went down to about 1%. And interestingly, if you see the little red triangles along the bottom part of the slide, that's the current season we're in, that's 2020 to 2021. And you can see that influenza activity has remained very low, likely again, at the aftermath of children not going to school and people staying at home and work being remote. But this audience knows that there was very significant bad news because of all of these closures. Dental offices everywhere needed to close for everything except emergency care. And on the slide, you can see that even emergency care suffered tremendously, and emergency department visits declined 42%. For serious illnesses such as heart attacks and strokes, people just stopped going to see physicians. They stopped accessing medical care and dental care overall because of tremendous fear of COVID-19. And this brings us to kind of the topic for today, which was when patients aren't being seen for their regular care, there was a very significant impact on vaccination rates across the United States. This is a slide from the CDC that is the dosing, the doses of vaccinations being ordered by offices. And you can see on March 13th, when the national emergency was declared, and very quickly thereafter, they were not needing to order as many vaccines because people weren't coming in to have these vaccines administered. The dark blue line are non-influenza doses, and the dashed line are measles-containing doses. And you see just the tremendous decrease in vaccines that were being administered and thus not being ordered. What we saw very shortly thereafter was a significant decline in vaccination status in infants in the United States. This is a report from the CDC that in Michigan, fewer than half of the infants who were 5 months of age and younger were up to date on vaccines. And this is very important because vaccines are timed to prevent the most serious illnesses. And so those 2- and 4-month vaccinations are just so important to protect those vulnerable infants. We saw that elsewhere, the vaccination problem was seen really in all ages. So this is in New York City. There was a 91% decrease in vaccination rates for children older than 2 years of age. And similar in Miami-Dade County in Florida, where there was a 60% decline in children's vaccines administered in April 2020 compared to 2019. The decline wasn't only for children, of course. Adults everywhere stopped accessing medical care, so vaccination rates for adults 65 and older dropped 83% compared to the previous year. And even for younger adults, there were declines of more than 60%. And you may think about this as just a timing problem. You think, okay, if we didn't give a 2-month-old their vaccines, we can just give them at 3 months. And you know, all we are is just a little bit behind. But this is one of the most important slides I want to cover today, which is the concept of herd immunity. You've probably heard a lot, heard in the other spelling, heard a lot about this because we discussed it extensively regarding COVID-19 vaccination and levels of immunity to try to stop the pandemic in the US and abroad. But I just want to go through these in some detail. So on the left-hand side of your screen, this is when there's no herd immunity. You see the gray figures are people who are susceptible to whatever illness we're talking about. So they don't have they have neither natural immunity nor do they have vaccine-mediated immunity. And you see the people who are represented in red are the people who are infected and spreading their illness, whatever illness we're talking about. We can use this as a metaphor for COVID, but really this works for all infectious illnesses. So when there are many susceptible people, the disease spreads quickly and freely. On the right-hand side of your screen, you see what can happen when herd immunity is achieved. So we have the introduction of the green people represented there. Those are people who are immune, either through vaccination or through natural immunity. And so you still have infected people represented in the red, but you see that the immune people tend to cushion the susceptible people who are the gray figures on the outside. And that is certainly what we've been working toward with the COVID vaccine rollout. You may know that measles vaccinations are so important, and because measles is so infectious, we actually need to maintain about 95% vaccination levels to prevent an outbreak of measles. For those of you who lived in Minnesota in 2017, you may remember we had an outbreak here where in the end, 75 cases of measles were diagnosed, 21 patients were hospitalized, and greater than 90% of those people who were infected during that time were unvaccinated people. So it's very important to maintain high vaccination levels when you have severe illness that can spread easily. So that applies to COVID, certainly. We know that vaccines are effective at preventing disease and death. For the cohort born between 1994 to 2018, which thankfully encompasses all of my children, we know that vaccination can prevent or did prevent 419 million illnesses, 26.8 million hospitalizations, and nearly 1 million deaths. So knowing all of this information and hearing about these vaccination declines across the country, there were very significant public relations efforts to try to reach out to people and reassure them that they could come back to offices, that healthcare providers were waiting for them, that we were doing everything possible to maintain our offices as safe and infection-free. We know that the dental community did the same. And this was really important to reassure people that they could come back and get their regular care. As Dr. Kademani just mentioned, the lack of regular preventive care misses those early head and neck cancers. And what we know is that it isn't just one thing that builds trust in communities, it actually is a team effort. So patients and families were targeted in some of these PR efforts to let them know that they should come back into the office and they should call their offices to see if they were up to date on immunizations. Healthcare professionals were encouraged to discuss vaccination at every single opportunity and to educate patients about the importance of vaccines. And advocacy organizations as well as CDC and otherwise were really trying to get some messages out to the community about coming back in and getting needed care. So today's talk is really about that center box there, healthcare professionals, because healthcare professionals include all of us from medicine, dentistry, and all ancillary services. That really this problem is every healthcare provider's responsibility to be sure we're providing good information to patients. So the concept of dentists as vaccinators or as educators is not new. Minnesota actually had on the Board of Dentistry scope of practice the ability to vaccinate against influenza long before the COVID pandemic here. Oregon in 2019 passed legislation so that their dentists could provide HPV vaccine as they saw, again, the need to augment vaccination efforts for HPV. They recognize that dentists are highly trained medical practitioners who are able to provide additional preventive care services, and that the integration of oral health with physical and behavioral health ultimately serves patients well. In Minnesota, you can see here just a month ago, legislation was passed for dentists to be able to provide COVID vaccine. The right-hand side of the slide is a snippet from the Minnesota Board of Dentistry that I just looked at a couple of weeks ago. And if you so desire, you can go there and click on those links to get training from the Minnesota Department of Health and be certified as a vaccine provider in the dental space. Around the country, dentists have been tapped as vaccination providers. This is just a snippet from the internet of an ambulance company in Massachusetts that was hiring dentists to ride along and to be able to provide vaccine in certain communities. But the human papillomavirus vaccine and the COVID-19 vaccine present unique challenges for dental communities. Number one is always the cost of vaccine. For the excuse me, for the COVID vaccine specifically, we are obviously offering it to patients without cost, but of course there's always cost involved. The vaccine supplies for COVID-19 specifically, the vaccine allotment and distribution has been a very tightly controlled kind of supply chain. The refrigeration, you may have heard the extraordinary refrigeration requirements specifically for the Pfizer vaccine that needs to be maintained at -80 degrees Celsius. Most office refrigerators won't be able to accommodate that. And then what today's focus is vaccine counseling and questions. How can we as providers give evidence-based information to our patients and families so they can get vaccinated and have all their questions answered regarding the safety, efficacy, side effects, and the long-term immunity. There's also the issue of immunization registries and being sure that we're able to track who's been vaccinated and when they need their next dose. And always a challenge in the dental community regarding medical billing, because as I understand it is quite tricky. So today I just want to leave you with the proposed role for dental professionals. The American Dental Association has already tapped into this, that really dentists and all dental professionals should consider themselves as resources for evidence-based information. The ADA has a COVID-19 toolkit, and this slide obviously is just a picture from that. But it basically just reiterates that we know that, that dentists are trusted healthcare providers. They have unique opportunities to serve as a resource for patients for evidence-based information, helping educate their own colleagues and the public about COVID-19 vaccine. So today we're going to try to cover a few of those in just a few minutes. Vaccine hesitancy. This is a movement that unfortunately is growing in the United States and elsewhere. This is very common in respect to the human papillomavirus vaccine and COVID-19. I like to comment that I don't think it's any coincidence that these vaccines have come to the market in an age of social media where misinformation can be easily propagated to vulnerable communities. I think it's important to know patients will be concerned about how new vaccines are. For HPV specifically, you should know that it's been available in the United States since 2006. So we're going on 15 years of experience and long-term data about the effect of HPV in preventing cancer. And there's great data coming out showing us that HPV is having a significant decrease in cervical cancer rates. And for head and neck cancer, we'll probably need to wait a couple more decades to see that full effect, but we know that it is working for the diseases and the cancers that we are most concerned about for human papillomavirus. For COVID-19, it is new, of course. We know that this vaccine came to market within 1 year. We like to remind people that Operation Warp Speed wasn't a plan to cut corners. It was just an extraordinary coming together of business, government, and the FDA to quickly bring something to market to try to stop the pandemic. So I think it's really important that people understand that messenger RNA technology has actually been around for more than a decade and was actually perfectly poised to be employed for the COVID vaccines. I think it's important for providers to clearly let patients know, why do you need this? For HPV, we have really tried to laser focus our message on cancer prevention. I think the rollout of the HPV vaccine had lots of missteps, but I think we are now very well suited to really give that information to families. This is preventing cancer. We want to prevent cancer for your child. For COVID-19, for sure, we want people to understand that all of the COVID-19 vaccines have been shown to prevent serious illness, hospitalization, and death. That's important. Side effects we're going to cover in a future slide, and long-term concerns as well. So COVID-19 vaccine side effects, I think it's important that everyone know. Hopefully, most people on this webinar have already had their COVID-19 vaccine, being in the healthcare sphere. But the most common side effects have been reported, including pain and swelling in the arm, fatigue, headache, muscle aches, chills, fevers that typically last 1 to 2 days. But for some people can actually limit their daily activities. So it's important to let patients know about that so they aren't surprised. For the Pfizer and Moderna vaccines, these side effects are more common after the second dose and in younger people. And the messaging really is to let people know that if you are experiencing side effects after your COVID-19 vaccine, typically they are mild, they are time limited, and that means that your immune system is working and you are producing antibodies. So people should not be necessarily afraid of side effects, but to be prepared for them and to use over-the-counter antipyretics if they need them. Tylenol, ibuprofen are absolutely appropriate, and you should encourage your families to utilize those if they're experiencing any of those side effects. Okay, and the last thing before I get to the last slide was just long-term effects. It is important that families know regarding HPV that HPV is safe and has been utilized around the world. Hundreds of millions of doses have been given. That vaccine is safe. We've had lots of time and experience with it. COVID-19, for our safety signals currently, the Pfizer and Moderna vaccine are looking very good. The FDA is actually meeting today about Johnson & Johnson, so we'll have more information soon about that. So I want to just wrap up so we have time for questions. I want you hopefully all know that oral health and overall health are bi-directional and intimately related. Dental and medical providers have a unique but synergistic relationship with patients. And we know that people need to hear consistent health messages that help build confidence. And when we all work together, the patient can win. So with that, I'll turn it back to Dr. Nina. I will stop sharing.
Thank you, Dr. Crespo. That was all phenomenal information. I think the one thing that has come up in the chat, and for everybody in the audience, this is information that is really important to take back to your patients. As both Dr. Kademani indicated, early detection is key. So, and with Dr. Crespo, prevention is key. So both of them have given us really important things to think about. So let's go to one of the questions that I had, Dr. Crespo and Dr. Kademani, is, does the increase in vaping among our younger patients cause any concern regarding new cases in the future?
So thank you very much for that question. You know, I think that in general, vaping is a relatively new phenomenon, and it takes a while for these pre-neoplastic and cancer-associated changes to occur in the oral mucosa. Most of the issues we've seen with vaping at the present time, although it is nicotine, we know it's the heat that's associated with nicotine that makes it more carcinogenic for oropharyngeal cancer. And what the actual vaping seems to do more so is to cause pulmonary problems rather than problems within the oral cavity.
I'll make one comment about vaping, and there is some evidence regarding COVID, at least, that actually vaping does increase the risk of COVID and or having a more serious bout with it. So just to know that. But yeah, thanks, Dr. Kademani, for talking about head and neck cancer.
I think there's a person who's raised their hands. If you don't mind putting your question in the Q&A chat box, because that helps us capture the question as well. And if you can put in your question, if that's what you're asking to do. I see a raised hand. Other than that, from my perspective, I have been, I think there's a question. Chewing nicotine gum long-term instead of smoking, can it cause oral throat or stomach cancer?
So I'll take that one. So if you look at the epidemiologic data, the answer would be yes. So if you, over a long period of time, use smokeless tobacco, it has a propensity to cause oropharyngeal cancer in the location that the smokeless tobacco is placed. Unlike smoking, that tends to be more diffuse. Whenever you put a quid of smokeless tobacco, that's usually the site that you get leukoplakia and dysplastic changes that can then degenerate into malignancy.
Thank you, Dr. Kademani. And for the people that don't know, I come from India, and a lot of the oral cancers that I saw when I was in India in dental school were oral cancers due to chewing tobacco, because they tend to hold the tobacco in the mouth. So that's where you saw the oral cancer. So thank you for your answer. I don't see any more Q&As. We're coming up at the top of the hour. Any final thoughts from our speakers as we wrap it up?
I'll just say a few words, and I just want to thank not only Tristan for actually sharing his story, but also for the partnership with Delta Dental. And it's terrific that we have so many people on the program, because it's us as a collective that are going to make a difference to be able to save people's lives. So I want to thank you for the opportunity.
Oh, I'll just say thank you so much. I am so grateful to see that so many people joined the webinar today. This was our first attempt at a virtual presentation of this information. And we really look forward to your feedback. Please do answer the surveys that will be sent to you. And I think Dr. Nina maybe has some closing comments.
Yes, first I want to thank both our speakers, Dr. Kademani and Dr. Crespo. It is just an awesome pleasure to have both of you speak. And then Tristan, wish you nothing but the very best. You are cool and you are such a fun speaker to have. So I'm super excited that you're on a great path, and you will be on that path with great treatment from Dr. Kademani.